Good afternoon, everyone. This is Roisin and Dr. Stevens, and I'm here today with Cora McGahan. Today's webinar is on healthcare audit for improvement, and we're delighted to have Cora with us today to present. So Cora's from a background of physiotherapy, actually the same as myself, and she's a member of the Chartered Institute of Ergonomics and Human Factors in the UK and a member of the Irish Ergonomics Society. She's Assistant National Director for Healthcare Audit within the HSC, and she's worked in a large number of areas, particularly in human factors and system safety for the last 25 years, both in Ireland but also in the UK and in Africa. She teaches in areas of system safety, human factors and healthcare audit on the RCSI Masters in Human Factors and Patient Safety and on the RCPI Quality Improvement Module, Essential Leadership Skills for New Consultants. And recently, I'm sure she's delighted to have submitted her PhD at the Centre of Innovative Human Systems within the School of Psychology at Trinity College. So we want the webinar to be as interactive as possible. So Cora will have time at the end to take questions and answers. So if you have any burning questions around the subject of audit for improvement, please do type them into the chat box, which is at the top right-hand corner of your screen. And we'll have time at the end to take those, and Cora will be delighted to do so. So without further ado, thanks a million, Cora. I'll hand over to you.
Thank you, Roisin, and thank you for the invitation to present this afternoon. So I'm delighted to be talking about healthcare audit for understanding and for improvement. And I'd be delighted to hear questions and deal with those at the end. And as Roisin said, if there are any burning questions throughout the presentation also, I'm happy to take those as well. So my presentation this afternoon is divided into 4 sections. The first, I will give an introduction to healthcare audit and what it is that we do. In the healthcare audit function, it's different to clinical audit, it's different to national clinical audit. So I'll just talk about the difference. The second part of my presentation is about healthcare audit in the context of the healthcare system. Third, healthcare audit for understanding system performance, and finally, I'll talk about healthcare audit for driving system improvement. So without further ado, I'll deal with the first item, the introduction to healthcare audit and what it is that we do. So the healthcare audit function in the HSC was established in 2010, approximately 8 years ago. At that stage, it was set up in the office of the then CEO, Professor Brendan Drum. It moved from there to the Quality and Clinical Care Division, from there to the Quality and Patient Safety Division, on to QID and on to QAVD. And I think that sentence says a lot about the constant merge and division and change, structural change that's going on in the HSC, and sometimes the challenge of not having baby being thrown out with bathwater and that kind of an environment, which is an environment that's familiar to everyone working in HC, which is constantly in flux and changing. So currently we're in QAVD under the Chief Clinical Officer Office. We have 17 people and we're recruiting. And our audit schedule is informed by risk information. And I'm going to come back to that an awful lot this afternoon because I'm going to be talking an awful lot about assurance because that's really our raison d'etre, to provide assurance that the organisation is complying with key standards that are important to help the organisation, the HSC, to achieve its objectives. And if it is going to do this, we need to be focusing on the key risks to achieving those objectives. So our audit schedule is informed by risk information from 5 different sources. So we look at information that's coming through the National Patient Experience Survey, information from the analysis of complaints, information from the analysis of incidents, information about gaps in the controls assurance process, and information about that's coming on the risk register through its processes. So the 2018-19 healthcare audit plan includes audits that span every part of the organisation, including the acute and community services, and is related to key safety risks that come through those 5 sources that I've talked about. And I'll be coming back to the plan later on as well in the presentation. So we provide assurance, and that's that word assurance again, and I will keep coming back to it during the presentation. And when we provide assurance, that's good. That means we find evidence that the organisation is complying or conforming with standards that are important for us to achieve the objectives of the HSC, which is to improve the health of the population. Where we can't find evidence of compliance and consequently where we can't provide assurance, these are triggers for quality improvement. They're the drivers for areas that need to improve conformance and compliance so that we can give assurance in the future. So we have a key role in the assurance framework. The HSE Assurance Framework 2015 talks about 4 levels of assurance. The first is, writing policies, local policies, procedures, protocols, and guidelines. The second is any work. Second level assurance comes from any work, any local review that gives assurance around compliance with those policies, procedures, protocols, and guidelines. The third level of assurance is where ourselves and healthcare audit and internal audit have an important role. We provide level 3 assurance in that we're independent and we collect data to identify compliance with policies and guidelines and can provide level 3 assurance. And then the fourth level of assurance that the HSE's assurance framework refers to is external assurance, such as from the controller and auditor in general in relation to financial standards, HIPAA, the Mental Health Commission, and other regulators. So that's the key role that we have in terms of providing level 3 independent assurance in HSE's controls assurance framework. We identify good practice for sharing across the system, and this is one of the ways that we can drive improvement. So if you look at our website, you'll see published summary reports that have been published since 2013, because each audit, be it an audit of compliance with early warning score, audit of compliance with HSE standards of practice for records management, whatever it is, we will usually randomly select a number of sites, sometimes averaging around about 9 sites. Each site will have its local data collected. We will look at the local data, find evidence of compliance or not, write a local site report which goes back to the senior accountable officer to consider the recommendations. But then all of the 9 site reports data will be collated in a national summary report about that topic, and that will be published on the HSE website. So that is a place where we publish and people can see the variation in compliance across sites, but also examples of excellence. So that's an opportunity for chief officers or hospital CEOs or the quality and safety structures above hospital groups and community organisations to be able to see the performance in terms of assurance of the various sites within the structure and examples of excellence for sharing across the structure. We test the effectiveness of internal controls and we provide evidence for signing the statement of internal controls. So, without going any further, I am going to give a definition. I only give 2 definitions in the whole presentation today, but I think they are important in the context of this topic. One is the definition of assurance that we use, and it is the confidence that controls are in place based on sufficient evidence and are operating efficiently and that the objectives are being met. And a couple of words that I'll focus on there is that controls. So the controls are the policies, the standards, the risk management processes that are in place to make sure that activities that are important for the HSE to achieve its objectives of improving the population of the health of the country, that those controls are in fact being adhered to. Sufficient evidence is, we will actually collect the raw evidence at site, the evidence that the controls are being adhered to or not, and we'll be able to determine then whether they're operating efficiently and that the objectives are being met. So just one more time, because it's important, we are about providing assurance, that is giving confidence that controls are in place based on sufficient evidence and are operating efficiently and that the objectives are being met. The second and final definition that I will refer to is assurance audit, because that's what we do. So an assurance audit is an objective examination of evidence for the word on the screen, I picked it over, for the purpose of providing an independent assessment of governance, accountability, risk management, and controls processes within an organisation. And examples may include compliance with national standards, policy, or guidelines. So that's where our audits are. They examine evidence for the purpose of providing an independent assessment. The word independent is very, very important. So when I talked about the controls assurance levels, I talked about level 1 being local policies and procedures, level 2 local review, that they are in place. So clinical audit would be a level 2 audit, because what you have there are local clinicians assessing compliance with a local clinical guideline with the purpose of improving clinical outcomes. That is extremely important but it's different in terms of the independence. So we are independent of that, and we will not just be looking at clinical standards or clinical guidelines. So the difference is subtle, but it's terribly important, and both audit processes are very important for assurance and improvement of the organisation. So we did independent assessment on the governance, accountability, risk management and control process within the organisation. Examples are the standards that I've got there, but we've also got examples of audits that we've published which were around compliance with legislation. So if you look at our website, there's one around the compliance with legislation around controlled drug use by our National Ambulance Services. So what we do, we audit compliance against clinical and non-clinical standards in both acute and community services. And some of my colleagues say, careful, Cora, when you talk about clinical there, it makes it seem like a clinical audit and it's important to be clear about the distinction. But I've given you the distinction area. Clinical audit, as you know it and as it is important, is about local clinicians looking at clinical guidelines and getting evidence of compliance with those to improve clinical outcomes. We're about getting evidence of conformance with standards, and they may be clinical or non-clinical. What we don't do is we don't audit compliance against financial standards. That's internal audit. And actually, if you put internal audit and healthcare audit together, it would be opposite sides of the same coin. Everything we do is very similar, almost identical, with the exception that internal audit focus on the financial aspect of things and we focus on everything else. And as I said before, we are not clinical audit. Clinical audit is its own very important thing, and not what we do. So I know that you will all know, I've just taken a screenshot of the Quality Improvement Division clinical audit page of the website, which is what we're not, but there's an excellent lady called Nicola O'Grady who leads up on that process in the Quality Improvement Division, so you can see the link to that. So just when I'm saying what we're not, if you're interested in knowing about what we're not, i.e. clinical audit, there's great information on the clinical audit page of the Quality Improvement website there. So going on to what it is that we are, I'm going to talk about healthcare audit in the context of the overall healthcare system, because remember I was talking about us being about assurance. That assurance is about finding evidence that we are complying with standards or legislation, and it's really important that those standards or legislation that we're monitoring compliance about are really honing in on the important activities or processes for driving of achieving the organization's objectives. So I'm going to talk about that in the context of systems, because it's only when we understand that we can really get a sense of how important it is to have policies, procedures, protocols and guidelines that are of the best possible quality that we can audit compliance against and give the best possible assurance. So I'm going to start off with the definition. Oh, actually, this is a third definition, but I promise you this is the last one. I'm going to just talk about a system for a minute. So a system is a perceived whole whose elements hang together because they continuously affect each other over time and they work towards a common purpose. So the purpose of our HSE is to improve the health of the population by a health service that service providers are proud to deliver and in which the public has confidence. That's the common purpose of all the different elements, be it acute hospital services, primary care services, mental health services, surgical services, elective services, scheduled services. The common purpose is that we're improving the health of the population that we serve. And the different elements of our health system will be working with each other, either positively or negatively. If they work well to achieve our purpose of improving the population health, if not, we won't do that so efficiently. But this is important in the presentation about healthcare audit and assurance in the context that I'm talking about having policies, procedures, protocols and guidelines that drive system improvement or drive the organisation to work in harmony to deliver an improvement in the health of the population or to achieve the HSE's purposes as efficiently as possible. So I'm conscious that I think a good deal of the participants on the teleconference line will have clinical backgrounds. So I've got some examples of some human systems that you'll be familiar with, just to help the thinking around systems. We're going to do a whistle-stop tour in the next few minutes on systems thinking and systems theory before I move back to the main topic. So I've got an example of a respiratory system, a cardiovascular system, and a gastrointestinal system. So here we've got examples of a system as a perceived whole whose elements hang together because they continuously affect each other over time and they work towards a common purpose. So if all the elements of the respiratory system are working in harmony, that's great. It will achieve its purpose of respiration. But if you have a lesion in the lung or the trachea, well, then we have one element of the system that's pulling against the rest, and it will work less efficiently to achieve the purpose of respiration, and so on. An ecosystem, just some more examples of systems, an economic system, an electoral system, a water system. So the system here is a perceived whole whose elements hang together because they continuously work towards the common purpose of making sure we've the right amount or the right temperature of water in the right place at the right time. If some aspect of it is not working well enough, it will pull the whole system down and it won't achieve having the right amount of warm water in the right place at the right time. So some characteristics of systems I'm highlighting here before I focus back in on healthcare systems, but I'm putting it out there as something that's important to have in mind when we're making sure we have the right policies, procedures, protocols, and guidelines in place. If we're in turn going to be able to monitor compliance with those or assess compliance to give assurance to the organisation or drive pointers for areas for quality improvement. And the first is that a system is only as strong as its weakest link. So if we have almost everything working really well, but not everything, well then the outcome for the service user isn't going to be great, or the outcome of improving the health of the population is going to be pulled back by the weak link. An example of this, I think, I was at a conference last Thursday where a service user spoke about, well, she was a carer of a service user who spoke about her husband who'd been in a car crash, and she talked about 4 years of the challenge of struggling with the system in the meantime. But she talked about some parts of it were excellent, diagnostics, radiology excellent, but other parts very, very difficult. It was hard, particularly to get the communication of patient information from tertiary settings to primary care settings, out of diagnostics into other care settings. So what she was saying is it didn't matter to me that diagnostics was excellent because, you know, he wasn't able to get the equipment that he needed quickly enough, and so the outcome for him was pulled down or pulled back. So the system's only as strong as its weakest link, and we need to be mindful of that when we're designing policy to make sure that it pulls all levels together. Elements of the system are interconnected. If we're looking at early warning score or the communication of critical information, if we get it right in one part but not in another, I'm thinking, say, if we design early warning systems with different colors and different ways of calculating in one part of the system, such as ED, and then we have it slightly different up on the wards, people are moving around between those, needing to make calculations and make decisions. If there's variation for good reason, for patient safety reason, that's okay. If there's not, that's a challenge. So the elements are interconnected, and we need to be conscious that a change in one part will impact on the other, and we need to be mindful that those changes need to be evidence-based and in the best interest of patient safety. And if so, we need to give a lot of support to the healthcare practitioners around the rationale for variations and differences, because it's easier to teach people how to do things the same way. So that's about making sure that we're mindful in writing policies, procedures, protocols, and guidelines, that they don't contradict or conflict or don't undermine what's happening in another place. Because if so, the assurance that we can have in terms of compliance becomes more limited. The relationship of the boundaries of elements is both challenging and important, and I've talked about that, say, the relationship between early warning score at A&E and up on the wards. And we need to make sure that policies go across boundaries where this is helpful and that they don't accentuate the differences at boundaries. Variation is sometimes good and sometimes bad, and we need to have an honest discussion when we're writing policy nationally about standardizing whatever it is that can be standardized, because even if there are different variation in correct solutions clinically, if we have junior doctors moving around between different parts of the system with different approaches, even if the different approaches are all correct, that variation makes it challenging for people who are moving around the system. And we need to have an honest discussion about what can be standardized and what can't, for patient safety reasons, for case mix reasons, and as I say, make sure that there's strong support to healthcare professionals to help them understand the rationale for those differences, which will help them as they struggle with variation across the system. A system has a knowledge to solve system problems, and that's part of the work of audit. It's a way of getting to know the problems And once there's knowledge about what problems are, knowledge of non-conformance and non-compliance, well, something can be done about it. And the sum of the whole is greater than the sum of the parts is another characteristic of systems, and that's kind of the opposite of the first bullet. In the first bullet, if you get everything right except one thing, you still pull outcome down. I talked about the story about the service user who was taking care of her husband who had a crash. It didn't matter that 90% of it was great, 10% that pulled it down meant that the outcome was still not as good as it could have been for her husband. The opposite is the corollary. When we have different parts of the system working very well together and communicating together, the impact it can have on achieving the objective of improving the health of the population is a multiplier effect. So that's just some system characteristics that are important for us to have in mind when we're designing the controls, the standards, the policies, the procedures, the protocols, the guidelines that we're seeking assurance of compliance against. Because as I say, the quality of assurance that we deliver is a function of the quality of the controls that we're measuring against, and so that's important. So looking at it from the health point of view, the health system's point of view, the purpose of the HC is to deliver a healthier Ireland with a high quality health service valued by all. That's from the HC Service Plan 2018. And it's expanded out in the Corporate Plan 2015-17, where it talks about improving the health of the population by a health service that's proud to deliver those services and in which the public has confidence. And if we design our controls with that in mind, when we're writing a new policy, when we're updating a policy, we're making sure that there's nothing in that will detract from the ability of the organisation to improve the health of the population. And that we're conscious of the knock-on effect our new policy could have on some other part of the system. And we're making sure that they're aligned and streamlined and we're not causing tension at the interfaces, and we're going across. If the standard or the policy or the control can go across acute and community services or across different parts of the service, that means that the interfaces between are governed. Well, then we're going to be able to get greater assurance towards achieving the objectives of improving the population, health of the population. So translating the slides I showed earlier about electoral systems and human systems and water systems into our health systems, at the centre of that we have our service users, the humans who use our service. And here's a high-tech picture here, but it could just as well be a primary care setting using child adult mental health services, immunisation clinics, more low-tech environments. And we have a picture here of the people who deliver services as well. So we've got two elements of the system here, the service user, the service provider. And we also have a third element in this picture. We have the team, or part of the team. Remembering that in health, teams are constantly merging and dividing and working in an environment of flux, in very dynamic environments, often under high stress, high pressure. So three elements of the system there, the human users, the human service providers, and the teams, which ideally includes service users as well. Another aspect of the system is the tasks that our healthcare professionals do. A picture here of someone living in a laboratory, but we have millions of tasks going on every day throughout our system. They vary, and we have equipment that's being used, low-tech, high-tech equipment. Here we have some very high-tech and some more low-tech. So we have the people, the human users, the teams, the tasks, the equipment on the picture so far. I've got a picture of a clinic here. So this could be, more low-tech kind of facilities. So I'm moving into the facilities that are used. And more high-tech facilities, tertiary hospital kind of environment. The next level of the system is the policies, procedures, protocols, environment that we live within. So I've included a picture of the HC's national framework for developing policies, procedures, protocols, and guidelines. Because that was published in December 2017, and it's a framework for making sure that all policies, procedures, protocols, and guidelines are evidence-based and robustly developed. And from our point of view, that's really, really important because if we're auditing against high-quality standards that are evidence-based, well, then the quality of assurance that we can give will be higher than if that's not the case. Moving on, the system also is everything okay?
Yeah, no, just checking the signs.
Checking the signs. There's a sound check going on here. So then there's obviously, the system also involves the regulatory environment. I've got a picture of a HICRA logo here, but that could just as well be the Mental Health Commission, the Health and Safety Authority, the professionally regulated, but they're all aspects of our system, as is the Department of Health, an external part of the system, and then the financial context that we live within. So when all elements the service user, the service providers, the teams, the tasks, the equipment that are being used, the environments we work within, the policies, procedures, protocols and guidelines that we work to, the external regulatory context, the financial context, the political context. When all of that is working, being mindful of the fact that each element needs to be working harmoniously together to achieve the outcome of an improved population health, that's really good. But when they're pulling against each other or not even conscious or mindful of that, well, we're not efficiently going to achieve the objective of improving the health of the population. From our point of view, in terms of providing assurance, it's really important that the policy, procedure, protocol and guidance is mindful of that system context, governs the key aspects of the system that are important for delivering the objectives of HSE, i.e. improving the health of the population that we serve. Here is the same thing, just in a kind of a more schematic representation. Service users at the centre, service providers next to them, the teams, the tasks outside that, the work environment, the organisational elements, the institutional context. And the point again being that it's really important that the controls that we are seeking assurance of compliance with need to be designed to drive those components of a system to work as harmoniously as possible together in their own right and as they relate to each other to achieve organisational improvement. And if and when that happens, the assurance that we can provide is really strong assurance that the organisation is controlling and doing what it can to achieve its outcomes as efficiently as possible. So in terms of measuring system performance, the wording at the centre here talks about in relation to each activity or area of interest. And by that, I mean the things that are most important for achieving the objectives of the organisation, improving the health of the population, must be identified and the appropriate performance measures and indicators put in place. So standards need to be defined. Healthcare audit is not involved in developing standards. We're involved in auditing compliance again. It would be wrong and it would detract from our independence if we were anyway involved. But as I said before, it's important, and one of the audits on our programme, which I'll refer to later on, is about for every guideline, policy, procedure, protocol that was published, the national one that was published post-December 2016 when the National Framework for How to Develop them was produced, we will be having a part of that audit, which is, does the policy, procedure, protocol or guideline we're auditing compliance with comply with the national framework or not? Because if it does, the assurance we can give will be even stronger. So once the standards are set to deal with the key issues that are important for driving the HSE to deliver improved outcomes, health outcomes for the population of Ireland, we come in then in terms of measuring the compliance with those audits and assessing the gap. So where we find compliance, that's great, we give assurance. Where we find a gap, we identify an area for improvement. So I'm going to move on to part 3 of my presentation, which is about healthcare audits for understanding system performance. And I've got a picture of somebody taking a photograph there because that's what audit is really. It's a snapshot. It's not ongoing data stream. It's a snapshot, a point in time of a finding whether the organisation is complying at a specific site at a specific time or not. So our healthcare audit plan is about to be published to our website. It was reviewed by the HSE Risk Committee and approved by the leadership team in March. We're just about to publish it to the website, but I'm going to spend a little bit of time talking about that because in the context of this, which is about understanding system performance, I've been talking a lot about the importance of making sure that we're looking at seeking evidence of compliance with the most pertinent standards to drive the improvement or give the assurance that's needed, most needed. So it's not very clear here, but it will be clear when it's published and you can see it on the website. So this is the first page of the audit schedule, and at the top there's a cell that says source of intelligence informing that this is a priority, and the first box underneath that a cell talks about controls assurance process. So these are the 5 sources of data that we use to inform the schedule to make sure that we were focusing on seeking assurance that what was most important to drive the organisation to achieve its objectives. So the first was around controls assurance, the second was the themes from the incident investigation data, the third was themes from the analysis of complaints, the fourth was the national patient experience survey data, and the fifth was information from risk and from the risk register process. The columns after that talk about whether or not the themes go across services, whether there's a potential to build on local audit, whether there's a potential for service user staff engagement, because all of those things we believe are important to give the best assurance. So the first theme on the left-hand side, as you see, I mentioned it before, is an audit of compliance with the HP National Framework for Developing Policies, Procedures, Protocols and Guidelines. So that's about making sure that the controls are evidence-based. So that's the first key audit that's on our schedule for 18 and 19. The next one is a new approach for us. Number 2 there pulls together 4 key core quality and safety issues. The first is around open disclosure, the second is around integrated risk management, the third is around quality and safety guidance, and the fourth is around incident management framework. So we're using a different approach to the way we've approached audit before, in that we're developing this as a self-assessment audit. So currently auditors are working with experts to develop a self-assessment audit tool which will go into the system, and this is about helping to embed these key protocols that are core for driving safety within the system into a wider audience than we can normally get if we go to 9 sites. And then what will happen is sites will do self-assessments, and we will randomly select sites and check to make sure that there's concordance between our findings when we look at the original evidence and the self-assessment to make sure there's concordance. The remaining themes on the audit schedule for 17 and 18 have focused on detecting and responding to patient deterioration, which is something that we've had on our schedule for a long time, but it's one of the key themes that keeps coming up through the risk and incident data. Discharge planning, patient deterioration, medication safety, and the management of complex patients is the 5th theme. 6th theme is conference and toileting, which is something that came up as important, particularly in many sources, but particularly the National Patient Experience Survey. Healthcare-acquired infections and antimicrobial resistance features as an audit theme, as does hydration and nutrition, falls, pressure ulcers, violence and aggression, emergency department delays. We're not going to trip over all the other audit work that's going on in terms of emergency department delays. We're going to focus on key themes that have come through safety data that's not already been looked at, particularly at the escalation protocols in response to ambulance off-road delays. And then there's just 1 or 2 more themes, if I can find them on my pages I've put together here. Bear with me for a second. Safeguarding vulnerable persons at risk of abuse. So that's the audit schedule. So going back to the heading of this, it was about healthcare audit for understanding system performance. What we're trying to do is we're trying to focus on the key critical risks to the tracking from system performance to hopefully find compliance and give assurance, and if not, pointers for quality improvement. So, summarising there, when we find compliance, that would be great. We will give a level of assurance to the organisation. Where we don't find compliance or conformance, and you'll hear that I use the word compliance or conformance, there's a pedantic difference between the two. Technically, compliance is used when you're complying with a piece of legislation. Conformance is used when you're complying with a standard that's not a piece of legislation. Kind of doesn't really matter that much, but if you want to be pedantic, that's why we use the differences. Focus for quality improvement. So the non-compliance and non-conformance is the focus for quality improvement. We will identify a variation, and then, as I say, it's vital for the organisation to decide if that variation is good or bad. And we will identify excellence, which is given back in the summary report that's published. It's for everyone to see. It's for the hospital group, the chief officer group, the governance structures within and above them, to look at those examples of excellence and to look at the variation and conformance, to check what the difference is, to see if they can recreate the conditions in the excellent performers or the well-conforming organisations and the others to drive improvement. So, focusing on the strengths of audit or any other method of measuring system performance, audit is certainly very strong at identifying problems and it can identify and acknowledge good performance. It can significantly help management control, and I suppose of all the different ways of measuring performance, this is audit for assurance strength. It can significantly help management control. It can improve management decision-making in that managers have real information about real performance, and it makes explicit about what is often left implicit. I'm often surprised when sites can perform well and local areas are surprised they hadn't expected to be so good. And sometimes when they don't comply as well, they would have expected it to be better. So what you've got is you're moving away from what you think the reality is to what the actual reality is, and audit can help enormously in getting to understand reality as opposed to what you think is going on. It's always important to know the weaknesses of any process in order to really harness the strengths. Audit doesn't explain the causes of problems. It does identify them, but it doesn't explain the causes. So those of you who received healthcare audit reports may be familiar with the recommendation around, we've identified this non-conformance and non-compliance. It's important for the senior most accountable officer to explore the reasons for non-compliance and put in place an action plan to address those. So it will identify the problem but not the cause. By the same token, doesn't necessarily solve the problem, because you need to have figured out the cause in order to solve the problem, but it certainly gets it started. There's a risk of emphasis on outputs and not on outcomes. But, if you think of the systems the systems talking that I did earlier on, focusing on outputs, if those outputs are important for achieving an aspect of control, and those controls are well designed as being important for health performance and achieving the objectives of the organisation, that's not a bad thing, but it's important to keep an eye on outcomes too, and it's important to know the difference. Measurement becomes an end in itself. That's the problem. It's not the all and the end all. It's terribly important, and it's my job, and I believe it's important, but it's what senior accountable officers and local staff do when they receive the information, and how they turn that into an opportunity for improvement or an opportunity to share the learning elsewhere across the organisation. And there is a risk of confusing science with reality. Audit is science done well, it follows good scientific methods, but it's only an aspect of reality, it's not all of it. We can't measure everything. However, it is really good to measure what we can and to know accurately what we can possibly know, and that is the strength of audit. Coming back to my diagram again, and talking about the healthcare audit role, as I say, other set standards, we find evidence of compliance with those and give assurance, or we find non-compliance, and that's a gap for quality improvement. So moving on to the piece then about healthcare audit for driving system improvement. As I mentioned earlier, we published to our website, and have done since 2013, a summary of all the site reports of the various audit team. And I've just included the four of the most recent publications. So there's one there around paediatric early warning score. There's one around audit of compliance with the National Ambulance Service procedure for appropriate hospital access for suspected stroke patients. One around audit of integrated risk management process, and one around compliance with section 7.2.3 of the safety incident management policy, particularly in relation to the decision not to proceed with an investigation of a serious reportable event. So those summary audits include a description of the performance of the various sites that were involved, and shows the strong compliers versus the weaker compliers, and most importantly shows examples of excellence. So that's a resource that's available to sites, hospital groups, community organisations, and to the quality and safety structures that pull all of those together to have information that can be translated into quality improvement. So I've added something on the left-hand side. The gaps identify areas where the local sites, the hospital groups, or the community areas, or the governance structures above those can share learning for system improvement, or improve the sites that are shown to need improvement. Other ways we can help with driving safety improvement is we re-audit and repeat audit. And the other thing is around follow-up with implementation recommendations. Now, when I came into post in April last year, there had been previously activity around following up implementation recommendations, but that had fallen back. And when I did an appraisal, a rapid appraisal of the function, it was something that service users and stakeholders came back very strongly saying, this needs to be revitalized, and particularly there was a very strong recommendation around doing the way internal audits do it. Now, so we've spent the time in the meantime linking with internal audit and updating our standard operating procedures to reinvigorate this process. So that is around self-assessment, so getting sites to self-assess their status around implementing recommendations of healthcare audits in the same way as they're required to do it for internal audits. In the context of key performance indicator for internal audit, which requires that 75% of recommendations must be implemented within 6 months, and 100% must be implemented within a year. And the internal audit then randomly selects sites to check the actual evidence of implementation against the self-assessment data that's returned. And as I say, the strong feedback from stakeholders, that included service users, doctors and nurses at the coalface, quality improvement managers, safety managers, people on the leadership team, people on the risk committee, was that we needed to do the same. So we're well underway in terms of reinvigorating, and that will be a way of driving improvement. But the most important way is the publication of the site reports, where people can see the performance or the assurance provided on the compliance of different sites, and particularly the examples of excellence, and particularly the opportunity to learn from sites that do well, what are the conditions there that may be reproducible at other sites to help them to do better as well. I only had 2 references there, but they are included in a reference section, and I think that leaves me finished just on time. So I was told I could talk for 40 minutes, so I think I've just done that, and I'll hand over then to Roisin to coordinate the remainder.
Yeah, brilliant. Thanks a million for all of that. That was great. So we do have 1 or 2 questions there. So I know we have put in, actually, first of all, we'd be delighted to get some feedback from anyone online. There's a link to the Survey Monkey. If people had 2 or 3 minutes just to fill that out first, that would be great. It will help us plan for future webinars. So Karen Reynolds has asked, which is something I was thinking as well as you presented, in terms of current demand, need and supply for healthcare audit, how are the topics selected in terms of what goes into the annual audit plan?
Okay, that's a really good question. Now, obviously, with 17 people, that's glad to have the 17 great people, but that's a relatively small number of people for the huge amount of control that it would be good to get assurance of. So we need to be very, very careful about focusing on key things that will make the most difference, which is why we design our audit plan to be based on organisation risk information. So as I said during the presentation, we looked at the gaps in the controls assurance process. We looked at the information that was coming through the National Patient Experience Survey. We looked at the themes that were coming through the analysis of complaints, the analysis of incidents, and the analysis of risks. And so you see in the audit plan that I was referring to, and which is due to be published this week, that there are, the 5 headings of the different data sources and the themes. The themes are on the left-hand side, and the data sources go across the top, and there's a yes in the box for the risk theme. So the theme around toileting and continence will come strongly through the service user experience. That was a big problem from their point of view. Others will have ticked all boxes. They'll have come through all sources. And I think if you look at the themes, I call them out there, false pressure ulcers, violence and aggression, emergency department delays, safeguarding vulnerable adults, management of the deteriorating patient, management of the complex patient with multiple comorbidities. They feel like the things, that are causing most harm to most people most often. So you would like to think that if we got assurance that we were complying with those, we would be doing as well as we can, or we'd be highlighting, putting spotlights on areas for improvement, because we find non-conformance and non-compliance, and they will be really important issues for local areas to grasp with if we want to make the most impact.
And just, Cora, would you mind elaborating a little bit more on, you mentioned that each site would get a feedback report.
Yeah.
So what's the follow-up then with that? Maybe just clarify again.
Okay, so local sites get an individual site report. So we will randomly select, say, approximately 9 sites for each audit theme. So those sites will receive a report which is related to their data and their conformance and their recommendations. And that will go to the senior most accountable officer. And, the quality and safety guidance, the Quality Improvement Division Quality and Risk Committee, or Quality and Safety Committee guidance, talks about those groups, the Quality and Safety Committees, taking information from various sources, including audit, and using that information to inform their quality improvement process. So the responsibility is very much within the senior accountable officer to take our reports and to put in place the recommendations. So when we send out a draft report for factual accuracy check and management comments, there is a page at the back which lists all the recommendations,
right.
And requires it to be returned with information about the person that will be responsible for putting in place that recommendation and the time frame by which they expect it to be implemented. That comes back to us, we finalise the report, and then they get their final report back to the Senior Accountable Officer with any factual inaccuracies corrected and with that management comment section completed. So that's their cue to take that and to make sure then that they are implementing the recommendation,
right,
by the time frame that they've
signed up to.
That they're going to. Yeah.
Okay, yeah. Great. And just one other thing that really struck me when we were talking there around the system and the multiple different parts that you have to consider, which is really complex. And I suppose one of the things we spoke about was the quality of the controls you're measuring against, that the audit is only as good as that.
Yeah.
So just wondering, could you elaborate a little bit more on the designing of those controls? Does the audit feed directly into the design aspect?
Technically, an audit function shouldn't, because an audit function should be constructively critical of the controls. You know, even that piece of our audit schedule, as you've seen, is a critique of the policy, procedure, protocol, and guidelines that we're auditing compliance against, and that will give an indicator of the strength of the assurance. And technically, our function should critique the framework for developing policies, procedures, protocols, and guidelines. You know, so we need to be careful about we can't be judge, jury, and executioner. If we're a truly independent function who's providing assurance, we need to be independent of. However, I suppose I'm on a webinar and I'm talking about it, but I'm talking about it in the context that we are committed to making sure that we can deliver the best quality assurance we possibly can. And we know that there's a correlation between that and the quality of the controls. So I guess it's in the context of even just saying it in this kind of forum, you know, making sure that those that are responsible for writing policies, procedures, protocols, and guidelines have that system awareness and system knowledge. That sense, you know, I've seen guidelines, most of which are great, but some of which have contradicted each other and which you think could cause tension in the system and which would distract from our ability to achieve the purpose of improving the health of the population. So we'd not be that involved, but we are committed to it getting better all the time and could critique any structures and processes to making sure the controls are as strong as they could possibly be. Yeah, that's great. That's very clear. Well, actually, there's no other questions coming in there online. So with that, I think I'm happy to sign off, and thank you very much for your time this afternoon. And just to say to those of you online, we do have 2 more webinars left before our summer break. So we'd be delighted to have actually Dr. Mark Roberts, who's the Clinical Director of Northern Ireland Safety Forum, which probably follows on quite nicely from what you were talking about there in terms of all of those safety programs and safety admin. So it'd be interesting to hear. He's talking about the relationship economy, and really a lot of it is about how relationships are so much part of improvement and we're trying to do. And then on the 3rd of July, we have Professor Lloyd Provost from the United States, so he's going to pick up on measurement for improvement. We have a number of other measurement webinars up on the website with the slides and the previous recordings up there. So if you just go to qualityimprovement.ie, you'll see the quality or the QI Talk 10 webpage. And just to thank Naomi, she's always here helping me with the administration of all of this. So thanks, Naomi, for that. And we'll see you then on June 20th. And thanks again for your time, Cora.